Hi all, welcome to Raaonline. Today we are going to deal with one important chamber of the heart which is often neglected. It is called forgotten ventricle, that is right ventricle. Traditionally, right ventricle is neglected and more difficult to treat than the left ventricle. Whenever you deal with right ventricle, it's a complex situation. You have to see whether the right ventricle was normal before or abnormal, whether the abnormality developed in the intraoperative period or the right ventricle was abnormal before. Then you have to look whether the PA pressure is normal or not, because the PA pressure can affect the right ventricle adversely. Then you have to look at the left ventricle, because due to back pressure this might affect the right ventricle. So you have to look whether the left ventricle function is normal or abnormal. Finally, you have to look whether the lung is normal or not, because a diseased lung will affect the right ventricle and lead to right heart failure, which is called as pulmonary. Apart from that, you have to see whether the patient is prone or supine. Prone helps in right ventricle function. At the same time, supine position can affect the right ventricle adversely. Whether it is a systolic or a diastolic failure, acute heart failure or chronic right heart failure, and the right ventricle of adult behaves differently from a congenital heart disease. So you have to look at so many things when treating in the right ventricle. Apart from that, whenever you institute a mechanical ventilation, the right ventricle is more affected than the left ventricle. Therefore, you have to look whether the patient is on spontaneous ventilation or mechanical ventilation. The patient is on volume control or pressure control. Pressure affects the right ventricle very adversely. Patient is in the inspiration phase or expiration phase. What happens to the right ventricle during inspiration and what happens during expiration? Whether you are delivering high tidal volume or low tidal volume, whether PEEP is present or not present. Finally, the frequency, whether it is an high frequency or normal frequency. So many variables you have to take in mechanical ventilation while dealing in a right ventricle. So dealing with right ventricle is not easy. It is a complex situation. The outline of this talk is we will deal with right ventricular physiology pertaining to comparing with left ventricle. What are the various etiology and pathology of right ventricular dysfunction? How you diagnose with traditional biomarkers, echo, ECG and echocardiogram? How do you ventilate a patient with right ventricular dysfunction? Finally, how you manage right ventricular dysfunction. Now coming to the first part, physiology. When compared to left ventricle, the right ventricle is thin wall. Its muscle mass is hardly 1/6 of the left ventricle and end diastolic thickness is only 1/3 of the left ventricle. Because the muscle thickness is less and muscle mass is less, the oxygen requirement for the right ventricle is minimal. That is the first physiological point you have to understand. From the supply side, it is supplied by all three major coronary artery. It receives continuous blood flow both in systolic as well as diastolic, and there is extensive collateral vessels helping the right ventricle. Apart from that, it receives nutrient blood flow from the Tibiacean veins. So your requirement is less and supply is very abundant, and the demand is very minimal, the supply is extensive. So right ventricle is always in a state of luxury perfusion. You have to understand that. But always remember, when you are in a luxury state, a small insult can cause enough trouble. Why it's so? Here, if you look at the right ventricle, the x-axis is arterial pressure and y-axis is the stroke volume. In the left ventricle, when the pressure is between 140 to 90, there is hardly any change in the stroke volume. The stroke volume drops from 110 to 90. But if you take the right ventricle, an increase of pressure from 20 to 30 decreases the stroke volume from 110 to 70. Here, the drop with the increase in pressure is almost very high. The bottom line of this image is right ventricle does not tolerate pressure overload. So, more pressure goes, the right ventricle output is going to be affected. That you have to understand. So, you have to limit the PA pressure as much as possible. When you compare right ventricle with left ventricle, the end diastolic volume is slightly higher than the left ventricle. The end diastolic volume is around 75. In the case of left ventricle, it is around 65. And compared, the mass is around 26 gram per meter squared. In left ventricle, it is almost 87. I said it is almost 1/5. And wall thickness, the right ventricle is around 2 to 5 millimeter. It is 7 to 11 in the left ventricle. Coming to the pressure, the normal right ventricular pressure, the systolic is around 25 millimeter of mercury and the diastolic is around 4. Whereas in left ventricle, it is 130 millimeter of mercury and 8 millimeter of mercury is the diastolic. Ventricular elastance, it is 1.3 in right ventricle, whereas it is around 5.48 in the left ventricle. And coming to PVR, actually it is between 70 to 130. In SVR, systemic vascular resistance for the aorta, roughly it is around 1200 to 1500. And as I explained in the previous slide, the right ventricle tolerates volume overload but does not tolerate the pressure overload. Here, the left ventricle tolerates the pressure overload better than the volume overload. And few finer structures between right ventricle and left ventricle. There is a higher density of adrenergic and cholinergic receptor in the right ventricle. Here, alpha adrenergic stimulation decreases the contractility in the right ventricle, but in the left ventricle, the alpha adrenergic stimulation increases the contractility. And in right ventricle, 50% of oxygen is extracted from the blood, whereas left ventricle, increased myocardial oxygen consumption, there is 75% oxygen extracted from the blood. Although the supply demand is in favor of right ventricle, when compared to left ventricle, it receives less coronary blood flow and the action potential duration is shorter when compared to the left ventricle. And in right ventricle, there is requirement of low energy to maintain output, but in left ventricle, higher energy is required to maintain the output. And here, alpha MHC expression is added, leading to faster shortening velocity. In left ventricle, there is beta MHC expression which leads to lower shortening velocity. And coming to the right ventricle contraction and then left ventricle contraction, here the free wall of the right ventricle shortens and the free wall moves towards the septum and the septum moves towards the free wall. That is how a contraction in right ventricle happens. But in left ventricle, there is chamber constriction and chamber shortening. And there is two layers of muscle fibers leading to longitudinal shortening in right ventricle, whereas in left ventricle, there is 3 layers of muscle fibers leading to torsional shortening. So, these are the various anatomical and physiological difference between right and left ventricle which comes in handy during treating the right ventricle, particularly in the perioperative period. Another important thing is how right ventricle reacts to increased pulmonary artery pressure. The normal right ventricle is semicircular versus circular of the left ventricle. Semicircular, it occupies less surface area. But when PAH happens, it assumes a spherical shape, which means that it has a higher cross-sectional area than the left ventricle. So your geometry is altered and the demand-supply ratio, which was in favor of right ventricle with PAH, gets altered. Because of greater cross-sectional area, it will be altered. Not only that, the more spherical shaped right ventricle results in an abnormal septal motion which impairs left ventricle. Here you can see the semicircle of right ventricle. As PAH sets in, pushes the septum towards the left ventricle and impairs the left ventricle function also. So in PAH, the right ventricle output only is not come down, but the left ventricular output is also altered. Another important thing which we look is the right ventricular wall stress. How much stress the right ventricle is undergoing. This right ventricular stress is inversely proportional to the ejection fraction. As the stress goes up, your ejection fraction comes down. So it is inversely proportional. This stress depends upon the pressure, diameter of the right ventricle and the wall thickness of the right ventricle. The right ventricular stress is low in normally functioning right ventricle and it is going to be very high in severe systolic dysfunction. Now coming to the survival of the patient with right ventricular dysfunction. There is a mild dysfunction, but your pulmonary artery pressure is normal and your right ventricular ejection fraction is normal. Here the survival at the end of 5 years is around 80% because both pulmonary artery and ejection fraction is maintained. Another group where you have normal pulmonary artery pressure but the ejection fraction is low. In another group where you have high pulmonary artery pressure but right ventricular ejection is preserved. Here pulmonary artery and ejection pressure compensates for each other. Still the survival will be around 60% at the end of 5 years. So one compensates for the pulmonary artery pressure and the ejection fraction. But the worst combination is you have a high pulmonary artery pressure but low ventricular ejection. Here both are compromised and survival is at the end of 5 years is hardly 20%. This one you have to understand. Now coming to the definition of right ventricular dysfunction. It is defined as a clinical syndrome where the right ventricle is not able to provide adequate blood to the pulmonary circulation at a normal central venous filling pressure. The right ventricle is not able to pump the blood into the pulmonary artery. That is the classical definition of right ventricular dysfunction. Hemodynamically, the right ventricular dysfunction or failure is usually recognized in the presence of high right atrial pressure, that is between 10 to 15 millimeter of mercury, or a right atrial to pulmonary capillary wedge pressure of 0.8, which is called isolated RV failure, and your cardiac index is low, 2.2 liter per minute per meter square. This is a hemodynamical definition. Now coming to the etiology. When does right ventricle fail? Three major factors are there. Right ventricular contractility may be affected, the pressure might increase and cause right ventricular failure, or the volume to the right ventricle might increase and cause failure. The contractility might be affected due to RV infarction due to a right coronary artery involvement, right-sided cardiomyopathy, or a perioperative right ventricular injury. When they cut open the right ventricle might be damaged. This all can affect the right ventricular contractility. Coming to the pressure overload, where the pulmonary artery pressure is going up and right ventricle is going to fail. Pulmonary embolism, left-sided cardiomyopathy which reflects back into the pulmonary artery, pulmonary stenosis, pericardial disease, positive pressure ventilation, left-sided valvular heart disease, pulmonary hypertension and ARDS. Here the pulmonary artery pressure is high and it reflects on the right ventricle and causes pressure overload on the right ventricle. Then you have the third etiology, which is the volume overload, which occurs with regurgitation lesion like pulmonary regurgitation and tricuspid regurgitation. And in case of sepsis and post cardiac transplantation, both the contractility and the pressure might be altered, and in case of left to right shunt in the congenital age group, the volume and pressure both might be altered, and in case of adult congenital heart disease, all the three variables will be altered, volume, pressure and contractility will be altered. And in cardiac surgery, the incidence of right heart failure and cardiac surgery can be slightly high. This is because of new onset of right ventricular ischemia or infarction during coronary artery bypass grafting, air embolus. Anatomically, the right coronary artery is at a slightly higher level than the left coronary system. So, whenever you come off bypass, the air tends to go into the right coronary artery and affect the right ventricle more commonly than the left ventricle. Then other causes of right ventricular failure in cardiac surgery includes pre-existing pulmonary hypertension, the mere institution of cardiopulmonary bypass, protamine can have dangerous allergic reaction and can affect the right ventricle, exclusive use of retrograde cardioplegia. Here your right ventricle is not protected and only the left ventricle is protected. So, while coming off, your right ventricle might fail, and cardiac transplantation and institution of LVAD fails to protect the right ventricle sometime. Now coming to pathophysiology, how the failure propagates further failure. You have high PVR and high pressure in the right ventricle. Normally, the right ventricle and pulmonary artery have a nice coupling system, and when the pressure goes up, this coupling system is lost and there is going to be RV dilatation. As I said earlier, when the dilatation increases, the RV wall stress increases and the demand supply alters and there is reduced coronary perfusion, RV ischemia happens and RV output is reduced, which leads to reduced overall cardiac output. This is on the pressure side. From the volume side, due to tricuspid or pulmonary regurgitation, there is going to be high volume overload which aggravates the tricuspid regurgitation. There is high right-sided filling pressure which leads to edema and organ congestion. This is on the volume side. When the tricuspid regurgitation increases, this invariably leads to R dilatation and the pressure effect also takes effect. Apart from that, there can be low aortic root pressure, and here now as the pressure increases, the right coronary artery perfusion is limited to systole. Previously I said it receives blood supply during systole and diastole. As the pressure goes up, the right coronary artery perfusion is limited only to the systole and ischemia can develop, and there can be compensatory tachycardia. And coming to left ventricle, there is ventricular interdependence. Your septum is pushed towards the left ventricle and there is ventricular septal shift, reduce LV preload, which also reduces the RV preload. This is the pathophysiology of failing right ventricle. Now coming to the workup of the patient with right ventricular dysfunction. First is history and physical examination, which is what are the various factors which are suggestive of right ventricular failure. Then the classical electrocardiogram and chest X-ray. You have to look for cardiac biomarker, but the gold standard is going to be your transthoracic echocardiogram. In the echocardiogram, you look for LV failure, and it can be due to acute MI, left-sided cardiomyopathy or valvular heart disease. Here, you have to do both left and right heart catheterization. It can be a right ventricular failure with an increased PA pressure. Here, you can look for pulmonary embolus, pulmonary hypertension, congenital heart disease or a lung disease. Here you have to do right heart catheterization, evaluate the lung, chest CT and ventilation perfusion scan and cardiac MRI. You can have RV failure without increase in pulmonary artery pressure, where you have to look for RV infarction, valvular heart disease, right-sided cardiomyopathy or a perioperative RV injury. Here you go for right and left heart catheterization and cardiac MRI. And you can have pericardial disease which can contribute to reduced cardiac output. Here you have to do a right heart catheterization and cardiac MRI. Now coming to history and clinical symptom. The symptom might be weakness with fatigue and dizziness due to reduced cardiac output. There can be dyspnea, diaphoresis. Patient might have decreased urine output, and confusion and mental state alteration. With physical examination, there might be an polycystic murmur at lower left sternal border radiating to the right lower sternal border. There can be loud P2 in case of pulmonary hypertension, peripheral pedal edema or anasarca. There might be organ congestion, cold extremity or wet and motile skid can be there. There will be raised CVP and right upper quadrant tenderness or hepatomegaly or splenomegaly, ascites. Now coming to the blood investigation. You do for a cardiac biomarker. You go for basal natriuretic peptide, N-terminal pro-basal natriuretic peptide or troponin. It can be, BNP can be elevated in sepsis, renal failure and LV dysfunction, but in the case of right ventricular failure, it predicts survival as well as prognosis. In case of subtle artery dysfunction, the BNP can help in risk stratification. Other biochemical marker which can prognosticate right ventricular failure include sodium, creatinine, C-reactive protein and transaminases. Transaminase comes in handy when there is hepatic congestion. And growth differentiation factor 15 plays a major role when the patient has acute pulmonary embolism. The increased value is a prognostic risk factor in PAH patient. Now coming to ECG, the electrocardiogram, mostly lot of findings with related to pulmonary artery hypertension. You might have a right axis deviation or right ventricular hypertrophy, tall QRS in V1 and V2, and there can be a right ventricular strain. These are all ECG finding for right ventricular dysfunction, particularly with PAH. Coming to chest X-ray, there might be RV enlargement. In case of PAH, there can be increased pulmonary vascularity and peripheral pruning can be there when the PAH is at the later stage. Now coming to the most important part, hemodynamic indices which is required for the diagnosis of right ventricular dysfunction. First you look at the right atrial pressure. This is the strongest hemodynamic prognostic factor for PAH. It gives an accurate reflection of RV function more than the pulmonary artery pressure. Here the right atrial pressure will be usually greater than 15 millimeter of mercury. Coming to cardiac index, the cardiac index is going to be low. Usually it is less than 2 liter per minute per meter squared. And another important factor which plays a major role in severe PAH is your pulmonary vascular resistance. Here the afterload to the right ventricle increases and your PVR goes up. So it helps in the differentiation of primary PAH, secondary PAH or other hyperdynamic states. Coming to right ventricular stroke index, it helps in the prognosis of right ventricular failure and it helps in the differentiation of whether the right ventricular failure is due to LVAD or it can also predict the transplantation free survival in dilated cardiomyopathy. And coming to another important hemodynamic variable is pulmonary artery impedance. Here you integrate the pulmonary vascular resistance along with pulmonary artery elastance, flow and pulsatile pressure. You integrate PVR with this three variable and the wave reflection is superior and it gives a more complete evaluation of right ventricular afterload than PVR alone. Coming to right ventricular stroke work index, it is calculated by mean arterial pressure minus right atrial pressure into right ventricle stroke volume index into 0.0136. Normally it is around 4 to 12. Coming to right ventricular stroke volume index, here it is mean arterial pressure minus right atrial pressure into your stroke volume index. Normally it is between 300 to 900. Less than 300 indicates right ventricular failure. Another important variable which comes in handy with hemodynamics in right ventricular dysfunction is your pulmonary artery pulsatility index. What is it? This is the difference between systolic PA pressure minus diastolic pressure divided by your CVP. When you say patient is in right ventricular failure, your cardiac index is less than 2.2 liter despite continuous high dose inotrope or more than one inotrope or vasopressor with the following hemodynamic variable. Your CVP is greater than 10 mm of mercury. Your CVP pulmonary capillary wedge pressure is above 0.63. Your pulmonary artery pulsatility index is less than 2 and your right ventricular stroke work index is less than 450. These are the various hemodynamic indices to say right ventricular failure. How will you differentiate severe RV dysfunction from moderate RV dysfunction with regard to hemodynamic indices? RA pressure is going to be greater in moderate RV dysfunction. In severe, it is going to be greater than 15. Your pulmonary artery systolic and diastolic pressure will increases as your RV dysfunction increases. Your right atrial versus pulmonary artery occlusion pressure ratio, it is approximately, normally it is between 0.5. In RV dysfunction, it is greater than 0.6 and in severe RV dysfunction, it is greater than 0.86. And PVR, it increases as your RV dysfunction increases. And pulmonary artery pulsatility index, it is normally greater than 2. In mild RV dysfunction, moderate to between less than 2. And in severe RV dysfunction, it is less than 1.5. And your stroke work index, it normally between 51 to 61. In RV dysfunction, it is less than 450. And severe RV dysfunction, it is less than 300. Now coming to the gold standard in diagnosing right ventricular dysfunction, echocardiogram. First and foremost is you look at the contractility of the right ventricle, you look at the volume parameters, right atrium and right ventricle parameter, whether any tricuspid regurgitation is there, the septum is shifted to the left or not, and whether there is pericardial effusion. These are all readily and easily available markers for right ventricular dysfunction, but it is limited by marked preload dependence. It is depending on the volume which comes to the right ventricle. And you look at the right ventricular systolic pressure and also calculate the pulmonary artery pressure as well as the RA pressure. TAPC tissue Doppler and T index, which is myocardial performance index, are more specific markers for right ventricular function and they are less dependent on preload. Normally on the highballing of right ventricle, the right ventricle is usually smaller than the left ventricle. In moderate, the right ventricle size is equal to the size of the left ventricle. In severe RV dysfunction, the right ventricle is larger than the left ventricle and the apex is formed by the right ventricle. This is a standard eyeballing to say whether right ventricle is normal or not. So, first is RV dilatation. The ratio of the diastolic diameter of the left ventricle and right ventricle, when you compare, the right ventricle diameter will be more than the left ventricle and the basal diameter greater than 41 millimeter. Systolic function of the right ventricle, your right ventricular fractional area change, which is the area change between systole and diastole, it is less than 35% in right ventricular dysfunction, and your septal shift towards the left ventricle, and the left ventricle assumes a D shape in right ventricular dysfunction. The wall thickness of the right ventricle will be greater than 5 millimeter, and whenever right ventricle fails and there is a volume overload, the IVC collapsibility is less than 15% and the diameter is greater than 2 centimeter, that is 21 millimeter. And tricuspid regurgitation, the peak systolic velocity of tricuspid regurgitation will be greater than 2.8 meter per second. And with TAPC, which is one of the indication of the systolic function, if it is less than 17 millimeter, the right ventricular dysfunction is there. And coming to Doppler tissue imaging of the right ventricle, your S prime velocity will be less than 9.5 centimeter per second. Longitudinal strain of the RV free wall less than 20%. And your myocardial performance index, which is a T index, will be greater than 0.54 by tissue Doppler imaging. These are all the various indices to say right ventricular dysfunction is there, and your ejection fraction will be less than 45%. And whenever failure is there, pericardial fluid which is greater than 5 mm diameter in diastole. Now coming to one more modality which can give a precise assessment of right ventricular function, which is MRI. Here in case of normal right ventricle, the right ventricle will be less than the left ventricle. In moderate, here you can see the right ventricle is equal to the size of left ventricle. In fact, it is more bigger than the right ventricle, more bigger than the left ventricle. And here you can see a right ventricle which is almost twice the size of the left ventricle, and severe TR is there. This is severe RV dysfunction. Here the RV is more than the left ventricle and TR has come in. Now coming to the most important part, as an anesthesiologist, we have to play a great role in this to reduce the right ventricular dysfunction. Your ventilatory strategy. You have to minimize your airway pressure as much as possible. The first and foremost is higher tidal volume and PEEP may increase your pulmonary artery pressure and right atrial pressure, and it worsens the tricuspid regurgitation, and most importantly, it increases the RV afterload. And PEEP also decreases your preload by diminishing your venous return. Therefore, you have to go with lowest tidal volume, lowest plateau pressure and lowest PEEP, which is needed to provide adequate ventilation and oxygenation. Lower tidal volume, by using it, you can also decrease inflammation, decrease your cytokine induced endothelial dysfunction. Permissive hypercapnia, high carbon dioxide, can increase your pulmonary artery pressure and worsens right ventricular failure through vasoconstriction. Therefore, excessive carbon dioxide should be always avoided. Hyperventilation, on the other hand, decreases your PA pressure. But you have to understand that hyperventilation should not be performed at the expense of high tidal volume. This tidal volume might increase your pressure and might adversely affect your right ventricle. And another important thing is increase in respiratory rate can cause dynamic hyperinflation, and then this can increase your intrathoracic pressure, and invariably your airway pressure goes up. And therefore, another important thing is increase in respiratory rate can cause dynamic inflation, and that this can increase your intrathoracic pressure. Because this happens, you have to monitor your airway pressure and flow time loop in the perioperative period. Prone position definitely unloads the right ventricle. It can limit the airway pressure as well as improve your alveolar ventilation. The effect of high frequency ventilation and RV function are poorly defined, but definite decrease in cardiac output can happen. Although transient improvement in oxygenation may be achieved with recurrent maneuver, this may decrease your venous return and cause hypotension. Therefore, it should be avoided or used with extreme caution when hypoxemia is present. Now coming to the goals of management, how we are going to manage your right ventricular dysfunction. First and foremost is you optimize your volume status with your volume parameter. Your RV preload you optimize. Next is you augment your cardiac output, increase the RV contractility. Third is you have to reduce your right ventricular afterload. There you reduce your PVR. So you optimize your preload, improve the right ventricular contractility, reduce the right ventricular resistance so that the right ventricle outflow is happening. Another important goal is you maintain your SVR. The SVR should be higher than the PVR, or in other words, you keep your PVR lower than the SVR. By doing this, you increase your RV perfusion pressure. And the final goal is maintain a sinus rhythm. When you compare the RV cardiac output with the right ventricular end-diastolic pressure, this is the normal curve. So you have two things here, your pulmonary vascular resistance and your inotropy. When you decrease your pulmonary vascular resistance and increase the inotropy of the right ventricle, the performance improve. When you have increased pulmonary vascular resistance or your inotropy, your contractility of the right ventricle is altered, or you too much volume overload, the curve is shifted towards the base and your output, right ventricular cardiac output, falls. To put in other ways, how can you improve the right ventricular performance? You have to do intervention that improve your left ventricular function. You have to do intervention that optimize your volume status. You have to do interventions to reduce your inflammatory mediators release. You have to take care of interventions which affects the lung. You reduce your hypoxic pulmonary vasoconstriction, your ventilatory parameters you should be altering, and you have to reduce the effect of pulmonary thromboembolism. You have to do intervention which target the microthrombi in the pulmonary as well as the coronary circulation. Finally, the most important thing is you have to do interventions which improves the RV inotropy and lusiotropy. Coming to the management, you have a acute right heart failure, your RV output is altered and it can be due to RV infarct, acute pulmonary embolism, or patient is in hypotension and shock which affects the right ventricle. Here the vasopressors, inotropes and inodilators comes in handy. The first line of defense against right ventricular dysfunction is dobutamine. If the RV dysfunction increases further, the next line is going to be your phosphodiesterase inhibitor. Whenever you use phosphodiesterase inhibitor, there is going to be a chance of hypotension. So you have to supplement with norepinephrine. That is the second line. Usually when there is a biventricular dysfunction or when milrinone is not working, you will go for levosimendan along with low dose vasopressin. The most important thing is you have to avoid dopamine and phenylephrine. And in case of rise pulmonary vascular resistance, you have to go with pulmonary vasodilator, inhaled nitric oxide or inhaled or intravenous prostacyclin. If this pharmacological therapy doesn't work, you have to go for rescue strategies like atrial septostomy, RVAD or ECMO, finally transplantation. And when you use the pharmacological agent, the most important thing is you have to look at the PVR-SVR ratio. When you use norepinephrine, it increases the SVR more than the PVR, but this is dose related and the ratio will be altered with increased dose. More doses you go, the PVR might go up rather than the SVR. In lower doses, the SVR will be higher than the PVR. Phenylephrine affects the PVR more than the SVR, so there is an increased PVR-SVR ratio which we don't want to happen. In case of low dose vasopressin, the SVR is more increased than the PVR, so the PVR-SVR ratio will be less. There can be diuresis. In case of norepinephrine usage, there can be lactic acidosis. Coming to inotropes, dobutamine decreases your PVR, decreases your SVR. It favorably alters your PVR-SVR ratio, but it causes tachycardia, but it improves the cardiac index. Coming to dopamine, it increases the PVR and the SVR, and when the PVR-SVR ratio, it has more deleterious effect on the PVR than SVR. It improves the cardiac index and causes tachycardia. By improving the cardiac output, it can cause natriuresis. Epinephrine, the effect on PVR and SVR is not much studied, but it improves the cardiac index and causes tachycardia. Coming to the inodilators, which comes in handy in the perioperative period in patients with severe RV dysfunction, your phosphodiesterase inhibitor reduces the PVR and SVR and it favorably alters the PVR-SVR ratio. And coming to levosimendan, again it favorably alters your PVR-SVR ratio. Coming to volume optimization, there are two things which can happen: hypervolemia and hypovolemia. If there is hypervolemia, first you try intermittent boluses of diuretics. If one diuretic doesn't work, you go for a combination of diuretic. Then they go for continuous infusion of loop diuretics. The goal is to maintain urine output of at least 750 ml to 1 liter per day. Don't forget, go for weight measurement and salt restriction. If none of this maneuver doesn't work out, you have to go for an early, continuous or intermittent renal replacement therapy. Coming to hypovolemia, here you try a volume challenge of 500 to 1000 ml with volume parameter monitoring. You have to go for stroke volume variation or IVC collapsibility index. But most important thing is no further volume if no effect. And coming to rhythm stabilization, here you should have a low threshold for cardioversion, particularly when hemodynamics are altered. Try antiarrhythmic. Pacemaker should be tried, and some arrhythmias are prone to cause RV dysfunction. In this case, you have to go for a CRT, resynchronization therapy. And the most important part, go for protective lung ventilation. Try to restrict your plateau pressure to less than 30 millimeter of mercury. Low tidal volume ventilation. Minimize the PEEP as much as possible. Avoid factors which increases the PVR, acidosis, hypoxemia and hypercarbia. Avoid auto PEEP. And coming to the underlying disease which causes RV dysfunction, you have to treat it. If there is pulmonary hypertension, diuretics, inhaled nitric oxide, inhaled or intravenous prostacyclin, phosphodiesterase inhibitor. In case of chronic pulmonary hypertension, bosentan and sildenafil, phosphodiesterase inhibitor can be tried. And pulmonary embolism, go for anticoagulation, thrombolytics and thrombectomy, either surgical or catheter can be done. In case of chronic pulmonary thromboembolism, go for thromboendarterectomy. In case of RV infarction due to right coronary artery infarct, go for percutaneous intervention and thrombolytics. LV dysfunction, treat the LV dysfunction with afterflow detection, diuretics, inotrope or mechanical support to the left ventricle. In case of congenital heart disease or valvular heart disease causing right ventricular dysfunction, you have to surgically correct it or go for percutaneous correction. In case of sepsis and acute lung injury, ALI, you go for volume resuscitation, broad spectrum antibiotics, lung protection ventilatory strategy. And in case of post cardiac surgery where right ventricular dysfunction is common, go with inhaled nitric oxide, your inhaled and intravenous prostacyclin, milrinone and levosimendan. So coming to future direction of treating right ventricle, you have to measure and be aware of right ventricle as it is very common for left ventricle. You have to treat the right ventricle very similar to left ventricle. Investigate the mechanism and role of hypertrophy in causing right ventricular dysfunction. What is the effect of lung disease on right ventricular function? So replicates of lot of right ventricles could be created so that you can go for targeted therapy and improve the outcome in right ventricular dysfunction. Thank you.